Hello, everyone, and welcome to our next Down Syndrome Center of Western Pennsylvania podcast. I am Dr. Kishore Velody, Medical Director of the Down Syndrome Center, and your host for this podcast. It's been really exciting to learn that episodes from this podcast have been downloaded in almost 20 countries across the world. So welcome to our local Pittsburgh families, and a special welcome also to those of you across the world who happen to find this podcast through other means. Well, today we're going to continue our discussion with Dr. Todd Otteson, who is a pediatric ear, nose, and throat specialist. Last time, Dr. Otteson gave us his thoughts on ear infections, and today we're going to tackle another common issue we see in Down syndrome, and that's sinusitis. Dr. Otteson, thanks for joining us again.
Thank you. It's good to be back.
Well, it's great to have you back. Can you start us off with the definition for sinusitis?
Sure. First, it requires a little bit of an explanation about the symptoms that occur with sinusitis. It's typically fever, it's nasal drainage. The color doesn't often matter, but it's usually yellowish to greenish drainage and pretty significant nasal congestion. The definitions of sinusitis depend on the length of time for symptoms. An acute sinusitis is basically anything shorter than 4 weeks. A subacute sinusitis would be from 4 weeks to 12 weeks, and then anything more than 12 weeks is considered chronic sinusitis. Those definitions are sometimes important because it can be different bacteria that grow for acute versus chronic. It can also be a different treatment pattern based on whether it's acute or chronic.
Okay, so now that we know about the different types of sinusitis, can you tell us how, say, maybe acute sinusitis is diagnosed?
For the acute sinusitis, it's really similar to how we would diagnose an ear infection, as we talked about. It's taking a good history, especially quantifying really how long the symptoms have been going on. It's the nasal exam and really getting an idea about the lining of the nose, how inflamed is it, and any drainage. And often we'll send a culture from what's called the middle meatus, which is really where the sinuses sort of all drain into that area. And that can sometimes be helpful to direct any antibiotics if needed.
Well, I'll be asking you some questions about antibiotic treatment in a little bit. But before I do, could you tell us why kids with Down syndrome seem to get more sinusitis infections than other kids?
So again, sort of similar to ear infections, I think it's two-pronged. It's the anatomy, especially the size of the sinuses, the sort of mid-face. Children with Down syndrome also have the immune problems that we talked about that go along with ear infections, and the same goes for sinus infections. I think that adenoids are more commonly a problem with children with Down syndrome, and certainly they can predispose to sinus infections as well. So taking all that into account is helpful.
You mentioned adenoids just now, and this is a term that a lot of our listeners have probably heard before, but could you tell us exactly where they are and what they are?
The adenoids are basically tonsil tissue, but just in a different location. They're basically straight to the back of the nose, just above the roof of the mouth. The reason that they're important, and they can be important both for sinus infections, but also for ear infections. Sinus infections, because if they harbor infection, then the infection can basically be seeded in the adenoids and out then into the sinuses. And they can be a problem with ear issues because if they're large, they can prevent the ear from draining well and can cause eustachian tube troubles.
So, given that there's such a potential source for problems for kids with Down syndrome, and then they're in a location that's hard to see on a regular exam, how do you know if the adenoids are enlarged or not?
There's a couple of ways to do that. One is to get an adenoid x-ray. That we can tell the adenoid size, but may or may not be able to tell, if they look infected. The other way is to do a flexible scope in the nose, to the back of the nose where the adenoids are, and see if they look infected, but also we can assess their size. Now, not every child is going to be cooperative for a scope, so often an x-ray is done in that scenario.
All right, thanks. Well, let's shift gears a little bit now. Let's say that you diagnose sinusitis. Is there any way to tell if the sinusitis symptoms are due to a bacteria or a virus? A bacterial infection could be treated with antibiotics, but antibiotics would not be helpful in a viral infection. So I think it's important to know which one you have.
That's a great question. I think often People try and quantify how much mucus there might be or what the color is to try and say it's bacterial or viral. And really, there's not one set. This is what is viral, this is what is bacterial. A lot of it is the history and how long the symptoms have been going on. And that's why usually if we've had symptoms longer than 10 days or so, then I would treat with an antibiotic. The best way, really tried and true, is the middle meatus culture that we talked about, because that will tell us definitively if it's bacterial or viral.
Thanks. So Todd, besides these clinical and microbiological clues that you've discussed, are there any other radiologic studies that can be helpful in diagnosing sinusitis?
So I mentioned that an adenoid X-ray can sometimes be helpful. Sometimes we would consider doing plain films of the sinuses, although really we only get the maxillary or cheek sinuses. The rest are very difficult to assess on plain film X-ray. And then the utility of a CAT scan is also one of the questions that we often get. And if it's just for an acute sinusitis, as long as it's not spread beyond the borders of the nose, then rarely, if ever, would we need to get a CAT scan. But children who, as we mentioned, have recurrent sinus infections or really chronic, meaning beyond the 12 weeks of symptoms, a CAT scan after a course of antibiotics can often be helpful, assessing if there are any anatomic abnormalities of the sinuses themselves, but also it can give us an idea if there are other issues beyond just the sinuses or the adenoids, and can help direct therapy as well.
So it seems as if the most useful and common way to diagnose sinusitis is by the clinical findings. So if you suspect bacterial sinusitis due to, let's say, more than 10 days of symptoms, well, how long would you treat with antibiotics for?
Usually in the ENT community, we would treat for 14 days for a sinus infection. We probably start to get better at about 7 to 10 days, but to prevent a pretty quick recurrence, we like to treat with 14 days.
Okay, so the treatment course is a long one, but I agree that it does seem to help prevent recurrences. Well, Todd, for our listeners, I'm just going to run quickly through some antibiotics that are used for sinusitis. Well, as it turns out, the typical antibiotics used for sinusitis are the same ones as those used for ear infections. We usually start with amoxicillin, and if there's no improvement with amoxicillin, other more broad-spectrum antibiotics like amoxicillin with clavulanic acid or cephalosporins could be used. Well, Todd, could you now take us through some other treatments that you could use, maybe even along with antibiotics, for the management of sinusitis?
I would group this into 3 groups: prevention, medications that's sometimes over-the-counter, sometimes antibiotic, and then possible surgical options. First, the usual common sense things like good hand washing and making sure that a clean environment, especially if it's an allergy type of child, making sure that everything that we can control in the environment is as we like it. The second is medications. So obviously we talked about antibiotic courses, but there are some other medications that can sometimes be helpful. I like a recipe of Afrin followed 5 minutes later with a nasal steroid spray like Nasonex or Flonase. And I think you get the decongestion of the Afrin and then the benefit of the anti-inflammatory steroid, and that can sometimes be helpful at cutting down on a lot of the nasal swelling. In turn, that cuts down on the number of sinus infections. So something we can do, which is topically, that doesn't involve the whole body. I also like Mucinex, just anecdotally. I think it helps kind of break up the secretions. Usually wouldn't do that in children younger than 2, but it serves a dual purpose of breaking up the mucus, and then it helps with any cough from postnasal drip, that kind of thing. There have been a lot of studies about which over-the-counter preparations are most effective, and I mentioned that Mucinex is more anecdotal. That's my own experience. That one is probably hit or miss on if the studies show that it's effective, but in my practice, I like to use it a lot. And then surgically, I mentioned the adenoids, and if we are having recurrent sinus infections, and investigation of the adenoid size and whether or not the adenoids appear infected can be helpful. Sometimes we'll do a sinus tap or an aspiration of the sinus to get any fluid that's there, especially so we can get a good culture sample so that we can direct any longer-term antibiotic therapy if need be.
That's a great overview. Well, here we are at the end of our podcast again, Todd. Thanks a lot for sharing your expertise with us today.
Perfect. Thanks for having me. It's been great.
Well, I really can't thank you enough for joining us for these past 2 podcasts. I hope to have you back again for one more podcast before you leave us here at Children's Hospital. Maybe we could talk about a very common issue we deal with together, like sleep apnea. Well, we'll look forward to hearing your thoughts on that issue next time. Until then, thanks as always to our listeners. We'll talk with you again soon. Bye-bye.